So thank you very much for, first of all, joining us. I know it's usually thank people at the end of a lecture, but this evening, unusual circumstances for all of us, of course, and I'm glad to be entering your homes this evening. I do appreciate you taking the time to log in from wherever you are, whether it's work or home, and joining us for hopefully an educational opportunity. And of course, we always want you to be healthy and to be safe with whomever you are. Now, whenever you have a lecture that you have to give, they always tell you if you're nervous about giving a lecture, you're supposed to envision the audience kind of naked. The problem this evening is that there's only one other individual in the audience with me, and that's Derek. So I'm going to go ahead and forego that and just go ahead and plan on what I envision all of you doing, hopefully cuddling up. Oh, wait a minute, we can't cuddle up on the couch this evening and watch this lecture. So hopefully if you're all being smart, you're keeping your social distancing this evening, and you have the opportunity to watch this lecture in the comfort of your home safely and away from your family. So we sort of alluded to this a little bit in the beginning. I always think it's always good during these lectures to keep a little bit informal, but that's a little bit challenging when we don't have a live audience here. So we will be taking questions at the end of this lecture. Please do pipe in, send them in, and then we're going to try to get through those questions at the end of the talk. Generally, I try to do those during the talk if anything comes up. But I think it's always important for you to understand who I am before I talk to you about things that I believe in. Who am I? And I think that we had a little bit of information there originally. So in terms of my medical training, I'm actually from Wisconsin, Madison, Wisconsin, and I stayed there to do my medical training for 4 years there, so I'm a Badger. And I stayed on there for 7 years to conduct my neurosurgical training. After that, I decided to go into the specialized aspect of neurosurgery, including spine surgery, and spent 1 year at the Cleveland Clinic training in both orthopedic and neurological spine surgery and developing my skills within spine surgery itself. That was in 2009 through 2010. In 2010, I was fortunate enough to come out here to Boulder, Colorado, which is a beautiful place. And for those of you who are watching from Boulder or around, this is the city of Boulder right here in the university. And I've been a partner in this organization since 2010. I always used to think of myself as a young buck, but I guess after being here for 10 years, I'm sort of getting up there as one of the older gentlemen. This is my office. This is what I do. Of course, this is not what I do full-time because this is a picture of me in the OR operating with my team. Part of my time is spent within my office, and part of my time is spent within the clinics, and typically it's a few days within each area. Over 10 years, I've done over 3,600 surgical cases, and over my total years of 18, I've done over 9,000 cases, probably 80 to 90% of which have been related to spinal surgery. But this does not just come from me. I do have a very supportive team. This is my nurse practitioner and my PA. Hopefully they're watching this evening as well. But we don't walk around our office with scalpels. We are surgeons, first and foremost, but we are first of all here to assist our patients in trying to develop a plan and strategy for how they have spinal problems. And so we're going to go through some of that this evening. But coming to visit us in the office, hopefully you'll find one of these friendly faces if you do decide to come over. I do love teaching and education, so these kinds of forums are very exciting for me. Over my 10 to 20 years here, I've done over 100 presentations, over 35 journal publications, written over 10 book chapters, and I've been participant and been a course director for probably over 40 educational courses in which we've taught over 750 medical professionals, including nursing and hospital staff, and I've taught over 1,600 different spinal surgeons from over 25 countries. So that's my passion. I love it. And I learn a lot from these individuals as I teach as well. So these are always great forums. But we're not here to talk about me. We're really here to talk about you. Why are we here? And when I say why are we here, why is it just me in an empty room with one individual? Well, hopefully we're here because we're going to address back pain. And that's what most of you, unfortunately, are suffering from. If we look at the statistics of back pain in and of itself here, over 65 million Americans suffer from back pain every year. That is a huge number of individuals that are impacted by this disease. Up to 80% of adults that experience low back pain, unfortunately, they suffer at some point during their life, but most episodes will resolve spontaneously, which is a great statistic for our patients in general. It is the second most common visit to the doctor after the common cold, but there's a huge economic burden to why we have to treat this disease. If you look at it, it's the leading cause of disability in the US. This is the latest statistics I was able to obtain actually this year. This means that there's a huge socioeconomic toll on the individuals within this country. And if you think about it, there's a significant drain on the healthcare system in and of itself. It's at an annual cost of over $500 billion a year. And to put that in perspective, they gave a stimulus program recently for this COVID of about $750 billion. So back pain in and of itself can swallow up that number pretty quickly. To give you a reference here, diabetes management per year is about $327 billion, and hypertension in and of itself is about $131 billion. So we're talking about a very significant economic problem within this country. And the workforce that is very active is affected about 45%. So our very active individuals out there are affected by this almost 50% of the time. So we're going to talk a little bit this evening about relieving spinal disc pain, diagnosing and treating some common spinal disorders. Obviously, within this 1 hour, we're going to try to go through a lot of information. A lot of the questions that people ask me are about back pain. Why do they have back pain? What are the things that contribute to their back pain? So I have a couple sort of bullet points here for you all. So physical loading due to occupational and sports really plays a limited role in back pain. So a lot of people come to me and say they've had factory jobs or they've been out there working and toiling most of their life, and that's what contributes to their back pain. Unfortunately, that's actually a very small component of what contributes to back pain. Heredity and genetics is actually one of the largest players of back issues. In fact, they found a high degree of similarity within twin populations that they've been able to study. The one thing that we can say scientifically it does contribute to advanced degeneration and breakdown of the spine is nicotine and tobacco. So typically the first recommendation I have for my patients is if you utilize nicotine or tobacco products, you're going to want to discontinue that if you want to try to slow down the process of advanced degeneration in your back. There's typically two types of back pain that we talk about. One is acute back pain and one is chronic back pain. As you can see statistically, acute back pain is typically 1/3 of the population and chronic back pain is about 60% of the population. When we talk about acute back pain, we're talking about that sudden, intense pain will typically resolve in and of itself after a few days or after a few weeks. Chronic back pain, however, which is the majority of the back pain that we actually have to address, is typically a dull, deep, aching pain, and typically will last over a duration of 3 months, and that's when we classify that as chronic. Now, there is an in-between there of a few weeks to 3 months, and that's typically classified as subacute, and that's a very small population of about 10% of those patients. What are the etiologies or the causes of back pain that we talk about? Well, degeneration is significant in terms of the numbers that we talk about. But there's other things that patients unfortunately suffer from that we see. Deformity, so when we hear about the word scoliosis and curvatures within our back, that's one etiology. We unfortunately cover trauma within our hospitals. People like to ski and be very active, especially in this community. So trauma is another source of pain for patients, so fractures of the spine, things like that. Infections, unfortunately, are on the rise as well. So we'll talk a little bit about that, but spontaneous infections or from IV drug use urinary tract infections. Finally, tumors and cancer, they can, and especially since we have patients that are living longer with unfortunate cancer diagnoses, these can also affect the spine or metastasis to the spine, and sometimes these are what we have to deal with as well. And finally, inflammatory conditions such as ankylosing spondylitis and such, which is a much smaller subset of the population that we have to deal with. But we're really going to hone in on the degenerative aspect of spine surgery, which is what the majority of what patients are that come into our office from an elective standpoint. Now, before we get into reviewing the types of back problems, we're going to first just review the quick anatomy because I think it's very helpful for individuals to see that. So here I have a picture of the spine. There's 3 columns of the spine here. So on the far left here is a picture of the spine from the front, and the far right is a picture of the spine from the back. And as you can see, it is very straight. Generally, when we look at the spine, we're supposed to be neutral individuals as we stand up straight. Our head is supposed to be centered over our pelvis, both in the frontal view, and then if we turn to the side, which is the view there in the middle, you'll notice that in a normal, appropriately balanced individual, there are normal curvatures to the spine there. And those curvatures are an S-curve that's designed to absorb the shock and the daily movement of what we have to do. Within the spine itself there's approximately 33 individual bones, and of course we have individuals with some that are more and some that are less, but we divide the spine typically into about 5 segments. The cervical spine is the neck region of the neck. So 7 vertebral bodies typically span that region. Then we have the thoracic space, which is what spans our rib cage, and that's typically 12 bones or vertebral bodies. Then we get down to the lumbar space, which is down just in what we call the small of our back within this region here. And then finally, there's the sacrum, which is typically 5 fused segments. And then we have the coccyx, which is the vestigial tail, which we as humans no longer have. But if you were to find it in dogs and monkeys and orangutans and things like that, that would still exist. So that's the tailbone that we no longer have. We talked about the curvature. So some people come into me and they talk about the abnormal curvature they have. We utilize the words kyphosis, lordosis, and stuff like that. So if we look at the spine in the middle here, typically the natural S-shaped curvature is like this. The head would be here, the legs would be here, just below the pelvis, and the cervical spine or the neck and the lumbar spine have identical curvatures of a lumbar lordosis. The thoracic and sacral regions of the spine have a convex curve or a kyphosis, okay? So when these get exaggerated, and especially as we get older and start to lean forward, we start to get out of balance, and this can be an etiology or source of back pain for individuals. But like we talked about, that S-shaped curve is designed for us to have the flexibility and to act as a shock absorber for the activities that we do. So let's hone in a little bit on a lumbar aspect of a back. So if we look at this from a spinal anatomy standpoint, sort of going in and delving a little bit deeper here, there's several components of the spine that we want to look at. One is the vertebral body. So if we looked at the spine from the top down, this is what the vertebral body would look like. This area here, which in a lateral or side projection is where the spinal column travels. So the spinal cord itself with the nerve roots travels through this space here. The discs are individual between the bones, and we typically think of those as shock absorbers, and that's made of a very soft material. And you're not supposed to make food references in anatomy, but of course doctors are not good listeners, but the consistency is something like crab meat, and I apologize for those of you that are eating crab right now, but it's not quite gelatinous, but it's a shock absorber that sits within a very firm outer ring of fibrous tissue. So almost like the external aspect of a radial tire, there's fibers that contain this material as a cushion. And then we have the facet joint. So if we look at this and spin the spine, so we're looking at it from the back, these are the spinous processes that are sticking out, and then the individual spinal segments integrate itself with the individual facet joints. Okay, so that is actually how we develop motion, and we think of this typically as a tripod. So the front of the spine is one aspect where there's a cushion, and then there's another aspect in the back where there's two other segmental motions within the spine. So the facet joints and the discs are what allow us to have motion. Now if we dive in a little bit deeper and add some spinal segments in there, so the vertebrae we've looked at, the disc we've looked at, and the facet joints we've looked at, but if we add the spinal nerves, they actually exit out through the segments that interdigitate between the spine, and that's where the nerves come out. And then within that space of the spinal cord, we have the epidural space. So when we talk about back pain and etiologies for pain, unfortunately, any of these structures can be pain generators. So when we're talking about back pain, we have to be thinking about the spinal segments as the facet joints, the discs, the vertebral bodies, the muscles, the ligaments that are the external supporting structures as also pain generators. So what are some of the common degenerative spinal conditions that we actually see within our office that people come in with? So there's the disc herniation, and if you look at this here, there's both a disc bulge and a disc herniation. And I tell people that typically these can be used one and the other. They sort of mean the same thing. Essentially what's happening is that the normal disc segment here, as you can see here looking at the spine from the side, part of that internal material, that crab meat that I discussed, is starting to squirt out. Now whether it's actually left, that fibrous material can lead to a bulge, or if it completely extracts itself, then it can become a herniation. Either way, they can both cause pain. So that's what they can be used interchangeably in my opinion. Then we talk about facet joint osteoarthritis as part of a degenerative disc disease. So everybody comes into our office saying that they have degenerative disc disease. The reality is most adults have this. As young children up to our teenage years, most of them do not have that, but then in our second decade of life, we start to break down, unfortunately. And what that means, as the discs start to lose their hydration and fluid, the bones start to react to that, and then you start to get the spinal disc degeneration, and osteophytes are the little bone that starts to grow around the disc material, and you start to get the degenerated disc material itself. So that's what degenerative disc disease, or DJD, is. It's a very common condition, not necessarily painful. Finally, spinal stenosis, so which we'll show some pictures of. Spinal stenosis is when we have the spinal canal and it's narrowed down. That can be a multitude of factors. That can be from a disc bulge, can be from an osteophyte complex here. It can be from epidural fat, it can be some ligaments thickening, and from facet joints that thicken. So lots of things can cause spinal stenosis, and I would say that the majority of conditions that I treat in my clinic are secondary to spinal stenosis. A spinal listhesis is a technological terminology that a lot of people we see in our clinic carry. And what that means is that one vertebral body is actually in misalignment from another vertebral body. So we're not talking about scoliosis. We're actually talking about a true anterior slip of one bone in relation to another one. And that's what a spondylolisthesis is. We will typically see about 2 or 3 of these a day in our clinics. And they don't always have to be symptomatic for patients. So we do see a lot of people that have muscle strains. A lot of people will make an appointment, come see us in about a month or 2, and most of their pain has resolved. So when we talk about muscle strains, we're really talking about, quote unquote, a pulled muscle. And that's the majority of back pain that we see in our clinics or that people suffer from in the community. So this will typically heal with non-operative treatments in time. So patience, which is the hardest thing for a lot of people that are suffering, is often a virtue in this world. So things like rest, heat, ice, anti-inflammatories, and conditions like that, stretching, will oftentimes help with that. A lot of patients come to our office with a condition of sciatica. People like to utilize the word sciatica. Sciatica is a terminology for a nerve, which is typically a bundle of nerves that come out from the lumbar spine, the lower aspect of our spine. So sciatica is a generalized term for that nerve pain. And what does it typically feel by, or what is it described as? It's typically a burning or a shooting pain that starts in the low back or the buttock and will typically radiate or shoot down the front or the back of the thigh and or the leg and down into the feet. Now there can be associated numbness with that symptom, so it doesn't just have to be pain. So sometimes patients will come in with just complaints of numbness into their legs, and that can have tingling, so pins and needles. They say that their leg feels like it's falling asleep, and or weakness. So they feel like their leg is flopping, or when they try to go upstairs, or they're trying to walk, they feel like their toe is catching, or their foot will catch on carpets and stairs. That's foot weakness. Typically it's unilateral, meaning one side of the body is affected. However, it can affect both sides if the nerves on both sides of the spine are affected. So what are the things that cause sciatica, the etiologies of this condition? Well, Piriformis Syndrome, of which I'll describe in a second, spinal stenosis, of which I described earlier, so a narrowing of the spinal canal, a herniated disc, of which we discussed earlier, the spondylolisthesis can cause that, tumor or cancers can cause that, and finally an infection. So sciatica is a terminology for the clinical presentation of pain in the legs, but it's not describing what the source of that pain is. And that's an important distinction there. When we talk about Piriformis Syndrome, this is something that we typically will have the therapist treat. It's not typically a surgical intervention, but we describe Piriformis Syndrome based on the anatomy of the area within the buttocks. So what you see here is the gluteus maximus is actually the large buttock muscle, okay? So if you peel this large muscle away, you get to the gluteus medius, the piriformis muscle, and here you can actually see the sciatic nerve exiting through this space. And remember that nerve is composed of a bundle of nerves that come from the lumbar spine. So when you start to develop tightness of this area or inflammation of this area, it becomes reactive to the nerve, and then the patient develops pain down the leg. So Piriformis Syndrome, as you can imagine, which can be secondary to any sort of prolonged sitting, car accidents, and falls onto the buttock, can cause a very similar condition to an etiology or a disc herniation or spinal stenosis within the spine. So similar, but a different treatment would be required for Piriformis Syndrome. It could be an injection or something like physical therapy. So what is spinal stenosis? I sort of described it, but it's really much easier to see it in a picture. So what you're seeing here is an MRI scan of an individual standing sideways. The bones, like we described, are these big square things here. And then you have the individual discs here, the spinal canal, which consists of the spinal cord within here and the nerves. Typically the space is enlarged. We have the nerve traveling here, but you can see right here how narrowed that space becomes. That's stenosis. Again, can be for a number of things within this condition. It's a disc herniation with some thickening of the ligament within this region. So combined, that causes compression of the spinal canal. Now this is a very common progression of aging, unfortunately. So like I said, it's one of the most common conditions that we have to treat as spinal surgeons. Most people do not develop symptoms, so they may get an MRI scan looking at another region of the body, and we may find that they have spinal stenosis on their MRI scan, in which case they're sent to our office and clinic, but they're doing just fine. So in that case, actually, most people do not require surgery, which is a good thing for individuals. When we examine the patient, most commonly we'll have a normal examination, and we don't typically have weakness and numbness, which is a good thing for patients. Now, many of you will actually relate to this picture here. So when we have spinal stenosis, again, from multiple etiologies, there's a very classic presentation that people will describe. So they will develop buttock or leg pain when they are ambulating or walking upright. So what they say is, if I try to walk a half a mile or 100 yards, they will start to develop symptoms in their buttocks and their legs. And if they stop and they rest, or if they bend forward, all of their symptoms abate and go away. And we call that the grocery cart sign. And a lot of people will go to the grocery store and they can shop all day long in this bent over position over the grocery cart. But if they try to stand up and do the same activity, they will develop severe pain into their buttock and legs. So that is what spinal stenosis is, and that is typically something that we can treat very well. Finally, a disc herniation. Why do discs herniate over time? Well, we talked about the degenerative process within the spine as we age, unfortunately. And typically what's happening is you're losing the elasticity or you're suffering an injury over time within those disc herniations. So the disc can then bulge or herniate to within the canal. And as you can see here in the upper right picture here, this is a disc squirting out into the canal space. And as the nerve is trying to exit the canal, it gets pinched. And that's what causes a severe shooting pain into the leg with or without weakness. A normal space looks like this, and the canal looks like this. If you have severe compression, you can develop pain, but if you leave it long enough, unfortunately, it can lead to permanent nerve damage and should require intervention sooner rather than later. This is what it looks like on an MRI scan. This is, again, an MRI looking at you in the same picture here. So we have the spinal canal right here. This is the spinal canal right here with the nerve roots within it. This is young and this is healthy. Here is where a spinal disc has herniated within the canal. It is completely severely stenotic, again, second to this disc herniation. And this is a massive disc herniation. And this may or may not be causing any symptoms for the patient. So again, we don't treat the pictures, we treat the patient in this situation. Now, in our world, we have things called red flag symptoms. And that means that when we see these presentations, we get very nervous. There's very few emergencies in our world, but these are things that are very important for patients to be very aware of clinically. So if they develop what we call saddle anesthesia, so where you sit on a saddle, on the bottom, if you develop any numbness within that region or cannot feel within that region, that is typically a trip to the emergency department. You do not want to lose bowel or bladder dysfunction, or what we call retention, so the inability to go to the bathroom, or going to the bathroom on yourself without control. That is not an elective situation. That is a trip to the emergency department and typically to surgery immediately if you develop those symptoms. If you have unexplained weight loss, we get very concerned. So if you present with back pain and you have weight loss that you cannot say that you're dieting, we get concerned about that. If you have a history of cancer, IV drug users, like we talked about, infections in the spine, people with prolonged steroid use have weakened spines, weakened immune systems, and people with diabetes have a higher risk of infections, and the other things like HIV and other infections can put you at higher risk. If you have a fever and an ongoing infection, so typically spinal infections can be without just IV drug use, so people that suffer from urinary tract infections, upper respiratory infections, skin boils, and things like that can lead to a spinal infection if the body is not capable of fighting that, secondary to cancer or immunosuppression from other medical conditions. So what are our treatment options? Typically, I tell my patients we divide them into two. So there's operative and there's non-operative. And typically, we don't jump to the operative condition unless we're talking about those more of the red flag or urgent situations with neurological problems. So with the assumption that you're not suffering from those things and it's mainly pain, we're going to talk about the non-operative interventions first. And we typically divide that up into three: medications, physical therapy, and injections. And if we talk about the operative interventions, we're talking about open and traditional surgeries versus MIS, or minimally invasive surgery, or minimal access surgery. So people often ask, hey, I've had severe pain, what do I do? I had this flare-up of pain. So the most important thing is self-care and lifestyle modifications. So we want to maintain your activity as tolerated. So some people like to push themselves when they have pain. We typically recommend that you back off from those activities. We do not typically recommend bed rest. That's an old way that we used to treat people, laying on the floor, laying on the bed for 5 days and then getting up. If you have to do it, maybe 24 hours of it, but we encourage people to be active and get up. Then we want them to return to normal activities ASAP. And when we talk about normal activities, we tell people that if an activity will cause you to have pain, you typically get to the point where you do not aggravate your back pain, okay? So we call that kissing the pain, not working through the pain. So back off and don't poke the bear, per se. People oftentimes ask about bed mattresses. I do not have any stake in any mattress companies within Colorado, although you guys have a lot out here. Typically, we recommend a medium to firm mattress versus something like a waterbed. Of course, waterbeds are now out of favor, or a very soft bed, so you want actually to have that good spinal support when you're sleeping or laying down. And they did a study looking at this, and a randomized trial where they looked at people with and without. They found 82% people had improvement in pain-related disability versus 62% assigned to firm mattress. So, a word about bracing. People sometimes come to our office with a brace that they've purchased within the CVS or Walgreens or things like that. Typically, we do not recommend the utilization of braces. If you need to use it, maybe for 24 hours, but we want your body to use your core. We do not want you to be reliant upon an external bracing mechanism for pain control. That is not the way to go from a long-term solution. And I always caution my patients. So when I watch TV or I'm watching the internet or things like that, and patients come in with bags full of stuff, people like to buy things on the internet. What I would say is there is a ton of stuff out there for which there's no scientific backing. This is only a sampling here of some of the things that I found last night online. There is no science to any of the stuff that they are doing. I have no idea what these devices are. Other than this very happy individual who actually appears to be the same lady in all of these products, I think, that she found. If you're this happy utilizing your devices, you probably don't need them. But I would say save your money and use it on those products that we endorse, things like anti-inflammatory medications, heat, ice, topical ointments, things like that. But these devices, they may feel good, and you can certainly utilize them, but we do not endorse them. And again, there's lots of them out there for individuals with back pain. So what are the things that we go through? We talked about medications, physical therapy, and injections. So let's just review some of the medication options. If patients come in, say that they're having a lot of pain, what are we recommending out there? What has been studied? So typically it's anti-inflammatory medications, so NSAIDs, so non-steroidal anti-inflammatory drugs like naproxen, Aleve, and things like that, if you can tolerate it. So you should always talk to your doctor first, because some people cannot take those medications. Or things like Tylenol, okay? So very simple medications to take, and typically we recommend taking it around the clock for a few days to really get the anti-inflammatory benefit. Now, you can talk about other medications in here. Things like gabapentin is a medication I use a lot for patients that have shooting pain into their legs. It's a medication we talk a lot about with regards to neuropathy in patients with diabetes. But the one thing we do not suggest doing anymore is the utilization of opioids or narcotic pain medications. We've really gone away from those kinds of things. So when they compared opioids to placebos or non-opioid medications, they did not find that it significantly reduced pain. So it's a good thing that we're moving away from that. All it really does is cause addiction. It's suggested only for chronic back pain and for short-term utilization, and it's very rarely for the individual that is severely disabled and for those who do not respond to other measures. So it's very important to understand we are really moving away from this as a society, and opioids and epidemics and things like that are all over the news, and that's been very helpful to us as practitioners because we don't want to prescribe this stuff anyway. With regards to physical therapy, I love physical therapy for my patients. In fact, a lot of patients also do things like Pilates, but the key with physical therapy is having a good physical therapist that understands your spinal problems. So there's various physical therapists out there that specialize, and we use a lot of those here within our community. They can teach you exercise therapy, so core strengthening, which is really important, teach you about flexion extension movements, and general physical fitness, which is really important. Finally, the utilization of spinal manipulation. I don't typically endorse rapid manipulation of the spine. They have shown that it's very low if you have your spine manipulated, but sometimes people can develop pain. Typically, we avoid it in patients that have severe or progressive neurological conditions. Now, physical therapy is one aspect that I recommend my patients get involved in. The other aspects are things like acupuncture, Pilates, chiropractic manipulation. So if you have good individuals that you can be recommended that do these things, I endorse them wholeheartedly. My answer is simply, if it doesn't work, don't use it. okay? But we try to put people in a regimented physical therapy program. They've actually published data on this showing that those individuals that are involved with a physical therapy program that is regimented versus a home exercise program that they think they can do on their own is not as good and with poorer outcomes than a regimented program, which is why we oftentimes endorse this. Finally, if you don't get better with anti-inflammatory medications, physical therapy, the next thing we start to going is to more invasive procedures. And we're not talking about surgery yet, we're talking about injections in the spine. And typically our pain colleagues, which are typically PM&R or anesthesiologists, will perform these procedures. There are lots of types of spinal injections that can occur. All are not created equal, so the most common are an epidural steroid injection. So as you can see here, they're actually injecting medication within the epidural space or on the spinal cord within the canal, or something called the facet block, where they're actually injecting within the joint that we discussed earlier. Typically the facet blocks are more for back pain. The epidural is typically more for the leg pain. So they have different utilizations, and so it's very important to understand that. And I'm not a pain doctor, but we send patients a lot for pain injections. So people always ask me, what is a steroid injection? Well, it kind of is what you think it is, but there's typically a biphasic response here, because there's typically two medications within there. One is a local anesthetic, the other is a steroid. The anesthetic typically provides you with an immediate response and will typically wear off after a few hours depending on what kind of medication they utilize. That will kick in right away, and then typically, hopefully over the next couple days, the steroid will start to take place, and it can hopefully last for a few weeks to a few months to maybe even a few years, and that's really important to utilize if you want to avoid having surgery. There are risks and benefits to having an injection, as you can imagine, having a needle injected into your back. Typically, the benefits are reduced inflammation, which in turn should reduce pain. If we can reduce pain, then we can improve your overall functionality, which is critical. Typically, people tolerate local injections with steroids. It will typically produce less side effects than taking oral steroids for patients because it's more localized to that area. It may avoid the need to utilize oral steroids, which are typically just systemic. And typically, the understanding is that it does not treat the underlying condition of the problem, but it will treat the symptoms. So if we get your symptoms under control, we're good. There are risks inherent to this. They are low risk, which is really good. In very rare circumstances, people can have side effects. They can have an infection, an allergic reaction. They can get bleeding, or they can develop worsening symptoms. That does happen rarely. And you can't get too many injections over time, as you can imagine, because it is a steroid. It can cause weakening of the bone, so osteoporosis. It can cause weakening of the ligaments within that region, tendons. People that are diabetic can affect their sugars. So you have to talk to your doctor and the pain doctors that do these before, so you understand the risks, benefits of utilizing these. So finally, we get to surgery. So after we've weeded out all of those patients, which typically 80% of the patients will get better with those non-operative interventions, we get to the very small subset of patients that actually get to the point of surgery. So not everyone that walks into our office gets surgery. If that was the case, we would be operating nonstop. We can typically help most patients with non-operative interventions, and that's where we guide you through that process. So in terms of surgery, there's no optimal timing, okay? Nobody's ever studied to say, when is the perfect time to do surgery? That's where we have to come in with sort of the art of medicine. There's no consensus on how long we should do non-operative interventions. For most people that present with sciatica, and I talked about this earlier, so a disc herniation in and of itself or a sciatic response will typically resolve in 75% of patients using those non-operative interventions. So that's what I said, 75 to 80% of you will get better with non-operative intervention. That is a great statistic for my patients. And when they looked at surgery versus prolonged non-operative interventions, they said there was an advantage to early surgery because it gives faster relief of pain and people have faster perceived recovery time. So if you're suffering for a year versus suffering for 6 months if you needed surgery, there's a little bit of a return to work and activities a little bit faster. So a little bit perceived improvement from that standpoint. Now we talk about surgery typically in two aspects. One is an absolute and one is a relative indication. So absolute means that we have to take you to surgery. That's cauda equina, which we talked about earlier, with a red flag symptom. So if you develop saddle anesthesia, bowel or bladder incontinence, severe neurological deficit that progresses very rapidly, we're not typically going to waste time with those non-operative interventions. We're going to take you to surgery. It's a very small subset of patients that we have to address that way. Relative indication is where we think it is appropriate for us to intervene with surgery. That means patients that have a failure to respond to the non-operative interventions that we talked about, or if you have severe intractable pain, typically I say quality of life is affected. So the two indications for surgery for me that are not considered absolute are pain that's affecting your quality of life or progressive neurological deficit. And if you meet those criteria, typically we're discussing surgery. Now, what are our surgical options? There is a huge grab bag of things that we can talk about. But really, in terms of spine surgery, there has been an evolution, and now we are at the point where we had a revolution within spine surgery. So what did we used to do back in the olden days? Well, we would first cut the individual open, we would find the problem in pathology, and then we would see and we would fix it. So cut and see was the way we used to do things. Over the last couple decades then, it's moved to see and cut. So the utilization of MRIs and CT scans allow us to see the pathology and the problem. So you see the disc herniation and the spinal stenosis, and we go in there and we fix the problem in a very targeted manner. Now, we are to the point of more technology integration within our surgical field. And this is where things are very exciting. So now, we have utilization of intraoperative image guidance, and we have robotic surgery. And this has now finally become a realistic intervention that we can use within the OR. And my analogy for individuals is, if you look at this road here, this is called Skipper's Canyon within New Zealand. This is a road that's notorious in New Zealand, and it was about 140 years ago that this was carved out of the canyon. It's a single lane road that they utilized in a mine, and it travels about 16.5 miles. In fact, rental car agencies won't allow you to take a car on there because it's so dangerous. Now, if you had to drive on this road in your car, would you rather drive a bus or would you rather use a train? And I would usually poll the audience, but I've given this talk enough that most people would want to be in a train because it's on a guided rail system and the chances of you tipping and falling off are much less. So it's that guidance and that accuracy that is what people like. So the predictability of it versus relying on an individual driving a bus or a car. So hang on to that thought for a second and let me show you what that means for us in spine surgery. This is what we used to utilize within the OR. This is an AP or a front view x-ray and a side view x-ray, and then the surgeon would have to use in their mind's eye or 3D rendition and creation of where we are, and then we would have to operate based on that. So we take 2D and then we have to transform it into 3D. Now we have intraoperative imaging, which transforms that data set for us, and now we have beautiful 3D pictures that we can use intraoperatively, and if we are doing something surgical that involves instrumentation, we can place the hardware without having to envision and imagine what that looks like. So that's what it looks like present day. That's intraoperative imaging, which is really critical. So you can see the difference there with where we are today. And this technology has been around for about 10 to 20 years, and it's getting better and better. Now we introduce robotics. So now when we have to do a spinal instrumentation here, this is me performing a instrumentation and the patient's on the table face down, and what you can see here then is the utilization of you can see me drilling very precisely through the robotic arm into the patient's spine. So here's what the rendition would look like. We're targeting this right here, and you can actually see us placing the hardware. We're going to take this device out very slowly, but again in a very precise manner, all right? And what does that look like? So that's the screen I'm looking at. So first, if we're doing instrumentation, again, what you're going to see here is the drill traveling through the planned trajectory of the screw within yellow, and you can see very accurately how this looks, okay? So we drill a pilot hole for the placement of a screw within this region. And then if we have to place a screw, we have mapped out and planned our screw, of which we'll talk about. And then you will see here, I'm going to bring the screw into place through this hole that we just previously drilled. And again, with great precision here, you're going to see that screw fall right into the planned trajectory of where we want to place this. Now it's important to understand why this is critical. Right here is the spinal cord and spinal canal. In the front of the spine here are soft structures. You can see we've planted the screw right where we want to put it, but there's vessels and arteries and your abdominal contents just in front of this. Spinal nerve roots right here. So we're working within a space here of approximately 5 to 6 millimeters, okay? That's what we're typically working in. And that's what that looks like with robotics. So why do we have computer and robotic-aided surgery, okay? So it allows us to have 3D visualization and reconstruction of the spine. It gives us real-time anatomy and feedback. So if you take a patient that is laying on a supine position and we take him, we flip him over, As you can imagine, there's intersegmental digitation of the spinal segments. I showed you what the spine looks like. It's flexible, so there's anatomy that changes, but we know the changes real time on the table, which is critical for us to be accurate with what we do. So it allows us to do preoperative planning of what you saw there. I placed my screws, and then intraoperatively, I executed my plan exactly how I wanted to, which means that it's predictable. No patient, no surgeon wants anything to be unpredictable or to add variables to surgery. That is how you get into trouble. So we improve patient outcomes by being predictable and accurate, which is critical for what we do. That's where we get greater surgical accuracy from placing them without this kind of technology. And now it's allowing us to perform more minimally invasive surgeries, okay? So we do smaller incisions, and rather than cut the muscles, we're splitting the muscles. And what does that mean for us? If we talk to patients about open and traditional versus minimally invasive surgeries, which is where we are going, minimally invasive surgery has shown, and we know, will decrease the length of time you spend in the hospital. It will decrease your risk of an infection. Therefore, you can decrease your amount of blood loss by reducing the amount of tissue that you're disrupting. That means you can get back to your work and activities faster, and there's less pain. So these are all a win for these technologies. So if they were to look at this in a patient, I know this looks very aggressive and this gives people seizures by looking at hardware and instrumentation, but if this is something a patient needs, what you can see here are some very small incisions within the back for a spinal fusion that traditionally would be a very long incision. So we're accomplishing things through much smaller incisions. Now, the right surgery for you, what's the right surgery for you? This is a very difficult question for me to answer for all of you, but there's a lot of factors that we have to take into place when we discuss this. So first of all, what is the cause of your symptoms? We discussed all these degenerative conditions, spinal tumors, fractures, all these things. So what is the source of your pain? That's what we have to first figure out. Once we have the source of your pain and we understand that, then we go to what are you presenting with? So just because you have a disc herniation, if you have no symptoms and we found it by accident or incidentally, we don't have to do anything. However, if you present, you have neurological deficits or problems, then we have to figure out what is the surgery that we need to tailor to you. Now, if you walk into our office and you're a 20-year-old versus a 90-year-old versus a 45-year-old, we need to look at your medical comorbidities. What does your heart look? What is your lungs like? What is your bone quality like? Do you have osteoporosis? So we need to tailor the surgery also to the factors of your medical conditions. So you can see it's not a one-size-fits-all sort of approach to our patients. We need to consider all of these conditions, and then our treatment goal is based upon taking all these factors, putting them together, and making this a mutual decision. What are your goals? What can we achieve for you that's reasonable? Are we swinging for the fences, or are we going to swing to something that gets you a good quality of life and make you better? Okay? So that is ultimately the most important thing. What do you want to achieve, and how are we going to get you to achieve that? I'm just going to show you a quick handful of slides of different types of surgeries, and then we're going to wrap up here. So if you had a disc herniation, this is a microdiscectomy, and sometimes there's endoscopic surgery here. So you can see again the anatomy. You have a disc herniation causing nerve compression here. We come in with a very small incision, and all we really need to do is remove that fragmented disc that's causing the nerve compression. That's a very successful surgery that we can do. It's usually outpatient, go home the same day with very good outcomes in general. If you suffer from spinal stenosis, so the compression of the spinal canal, typically it's either one or multiple segments. You could do something called a laminectomy or a laminotomy. Again, if we look at the spine, here's the spinal cord and the spinous process here. This space is compressed from a number of sources. We go in there and we cut out the spinous process, and we do something called a laminectomy. That's what the view looks like, and we decompress the spinal cord and the nerves. We give it room so that there's no longer compression, pain, claudication, walking, difficulty with those kinds of things. That's a laminectomy. No instrumentation or hardware for any of these surgeries. Now, if you have a condition that requires instrumentation, if that's appropriate for you based on what we've been discussing, this is what it may look like. This is a multi-level spinal fusion. This is looking at you from the front to back. This is from the side. You can see some screws and then some cages within the disc spaces. And what we are doing here is stabilizing the spine. Okay, so if you have instability or you suffer from severe back pain and we deem that a spinal fusion is appropriate for you, this would be the appropriate surgery. If you have a disc herniation, this would not be the appropriate surgery unless we feel that you need it. So again, doesn't mean that everybody walks out with one of these. This might be the appropriate surgery for the individual. This might also be an appropriate surgery for an individual. If you come into our office and you're suffering from pain secondary to scoliosis, or your scoliosis is progressing, meaning that the curvature over time is becoming more severe or reaches some maximal point where now you're suffering from difficulty with eating because your chest cavity is shrinking, meaning you're losing weight, or you can't breathe deeply, so you're suffering from pneumonias, and you have severe back pain, or you're leaning forward all the time, or you're off balance, we may need to straighten you out, and this may be the appropriate surgery for you. That would not be a discectomy type of surgery. In the neck, cervical spine, people always ask about artificial discs. That's one option. This is between two vertebral segments here. This is a disc that's been removed, and this is just one example of multiple artificial discs that exist out there. So that's an artificial disc within the neck. This is a similar surgery through the same approach, but this is called an ACDF, an anterior through the front of the neck, cervical of the neck, discectomy. We'll remove the disc that you can see above and below that we've removed and put in a small spacer, fusion, ACDF. And one of these may be appropriate for you. That's for us to walk through what are the proper indications for you as a patient and an individual. So what is our role? Our role is not here to tell you what to do. My role and my team's role, of who you saw earlier, is to navigate you through this process. It is very complicated. There's not, like I mentioned, a one-size-fits-all type of solution for the individual. We have to take all of those factors in, consider them, and then help you, the individual, make the right decision that we feel will give you the best outcome. So I always tell my patients, if you're going to come in and you're going to contemplate any type of surgery, we want the outcome to be better than when you walked into my office. There is no reason to perform a surgery if you're going to walk out and be the same individual as you walked in. There's no reason to put you through the risk of the surgery. We want you to be better. So the key here is to get your life back. And that's really important to have that mutual goal. That's what ultimately leads to your success and what makes us happy with what you achieve. That's all I really have for you. This is my office phone number here. I have a number of partners that also perform spinal surgery. And of course, we would love to see you if you have any problems. Again, we do not carry scalpels in our office. If you need to come down and have a conversation about what's the best approach, we're happy to guide you through the process, refer you over to the therapists, the doctors for injections. We don't typically do medication management. We can talk to you about those options with your primary care doctor as well. So with that, I'm going to go ahead and wrap this up, and I think we're going to go ahead and turn it over for questions.
Thank you, Dr. Rajpal. We have quite a few questions from our online viewers. I have my first one. I have transformal stenosis of my C5 and C6 on the right. I have terrible aching and paranesthesis on my right arm. I have an epidural, and I'm wondering if robotic surgery would work here. There's been talk of fusion, but I'm not sure about this.
So that's a great question. So there's sort of two questions nestled in there at the same time. One is about the surgical procedure, and one is about the utilization of robots. So first, to address the question about surgery, so sounds like the individual has nerve impingement, and that would be addressed, again, depending on the films. We would want to know where that nerve impingement is. So if we have spinal cord compression in the middle versus just in the corner, we're going to address this surgically. So in the neck or even anywhere in the spine, we can approach it from the front, the side, or the back. So this is true for anybody that comes in with a problem. So for this individual with neck pain that's not responded to appropriate conservative management, medications, therapies, and injections, then we're going to want to look at the films and decide whether or not you're an appropriate candidate for a discectomy and fusion, of which we talked about right back here. And we need to open up these spaces of the nerves, or an artificial disc. Again, there's multiple conditions we have to consider here. And then finally, robotic surgery in and of itself today, we cannot indicate any robotic for this type of surgery. That is coming down the road. And
next question we have from our online. Would an inversion table relieve pain by stretching?
Yeah, so people love inversion tables. I always tell people inversion tables are great for people like Batman. We hang upside down. What it does is it allows the spine to stretch out, as we showed you the anatomy. So all day long, gravity will force you down. We shrink over time. If we hang upside down, the weight of our body starts to stretch things out. So as you can see here in this picture, these spinal nerve roots, as we start to compress this space, the nerves get tightened down. Inversion tables are great because they will at least open up the space by gravity. The problem is we can't live our lives upside down. So there's not typically harm for most people. Again, I don't know your condition individually, but there's typically not harm to using an inversion table. The problem is it's not a long-term solution because the pain relief is temporary. because you have to walk upright, unfortunately.
Question, 1 second. Are you or surgeons in your practice performing elective surgeries or seeing patients now during the coronavirus crisis in Boulder?
So we are not. We are subspecialists within our field. So we are, first of all, not treating any patients with COVID as far as I'm aware of. And I can't really comment on, of course, there's COVID patients out there. But as a neurosurgeon, if somebody has a condition that is what we consider elective, we would obviously want them not to be infected, not come to the hospital from that perspective. So we are currently on hold for elective surgeries. Obviously, if there's emergencies, we would have to take this on a case-by-case situation.
Another question here. I have a diastematically in my lumbar spinal cord causing scoliosis. Is Mazor an option for repair? Told traditional surgery was too risky.
I didn't hear the last part of the question.
They were told that traditional surgery was too risky.
So that's tricky. So so what they're talking about is a spina bifida situation here. That's a very specific condition. And so what's happening here is the individual probably has something that they were born with, where the spinal nerves themselves are either being tethered, and it's incomplete development of within the spinal canal and cord. So we did a lot of these within the university in my training, but it's not necessarily too risky. It depends on the individual situation, but we did a lot of these when I was in my training. I would typically actually refer that individual to the university because multiple specialists need to be involved, typically a urologist for bladder function, a rehab doctor, sometimes orthopedic surgeons need to be involved for lower extremity problems. So that's a complicated question, but not necessarily too risky as far as I'm aware, but there might be other factors involved.
Okay. Are you doing endoscopic spine surgery?
So that's a great question. So I was just reading a paper last night. So endoscopic spine surgery is at the moment being utilized for disc herniations. It is taking off around the world. There are pluses and minuses to endoscopic spine surgery. So what they're referring to in this is the picture here. The endoscope is actually introduced from a lateral aspect here to reduce the amount of tissue disruption. And so the only challenge here is the cost of the equipment and getting it within the United States at the moment and getting surgeons trained. It's probably something that I will get trained on, but not at the moment. If you look at the outcomes for standard traditional open versus tubular versus endoscopic discectomies, the new paper that just came out, there are pluses and minuses to all of those approaches. The endoscopic surgery is not necessarily the best approach in terms of everything.
And what else is coming for future technology in spine surgery?
Yeah, so spine surgery is actually, the technological developments that have come within the last 5 to 10 years has just exploded. So endoscopic spine surgery is actually one of those things. Robotic surgery has actually been around for quite some time, but it has not been around enough for us to say, I would say, to be a useful technology that we're using. So I think that we have to start talking about the robotic surgery within other aspects of the spine. And we got to think about other things like AI, so artificial intelligence. We're talking about virtual suites for surgery. So seeing things before you get there and such. So integrating that within spinal surgery and actually being able to perform more surgeries that are in more minimally invasive. So these are things that are in the pipeline that I can envision us coming to utilize within our OR within the next 5 to 10 years. It's exciting.
Okay, we have another one. Please describe how effective are core strengthening exercise, e.g. crunches, for helping spondylolisthesis?
So I actually think that core strengthening is really good. I don't necessarily just endorse crunches. I think you need to have a good physical therapist or chiropractor or an individual that can teach you other core strengthening exercises. But the spondylolisthesis, there's different types out there, but many people have these for a long time within their life. And there's different types of spondylolisthesis that we diagnose. But most spondylolisthesis can be treated non-operatively with conservative management such as physical therapy and core strengthening for quite some time before we get there. So we see a lot of athletes with these problems. Most of them do not need surgery for several decades of their life. So I actually would endorse that a lot.
Great. And are you accepting new patients, and how soon can a patient see you?
We're always accepting new patients, and we'd love to see you ASAP. Right now, there's actually a slowdown in general with healthcare because of this COVID virus situation, but we can get people in relatively quickly to see us.
Great. All right. Here's another one from guest 63. My L4, L5, S1 are fusing on the left side of my spine. Should it fuse on its own, or would robotic surgery be successful?
Well, again, the question is, it's fusing on its own. So probably what they're talking about, I presume in this condition, is osteophyte formation. So the body is trying to stabilize the spine. What I'm assuming in this situation is the patient has not fused yet. If they're not, and the back pain is diagnosed to be a source of their problem, and we need to fuse it, we can certainly do that with robotics. There are inflammatory conditions where the patient actually will auto-fuse if that's what they're talking about, so something like ankylosing spondylitis. So assuming that's not the condition they're talking about, yes, we can perform that with the robot.
Great. And here's another one from guest 12. Surgical options available for clavicle pinched nerve, how to relieve pressure?
We do not do that. Typically, we send that to the vascular or general surgeons if the pain is typically associated with the clavicle.
Okay. And what treatments would you perform with the Mazor spine robot?
So right now, the robotic spine surgery is an application for placement of hardware. There's going to be applications perhaps to maybe hold a retractor such as this, and maybe to perform a discectomy in the future. That's stuff, again, that we talked about in the future. At the moment, it helps us really guide with spinal surgery, so placement of hardware, planning out scoliosis surgery, correcting people's curves, and things like that. So we can do it for very small surgeries or very large surgeries at the moment.
Great. All right. And we do have another one here. Do you feel that somebody with a known herniated disc should continue golfing if they are able to tolerate the pain?
So I think that's a very tricky question. We have a lot of golfers. There was just an addition placed on golfers and herniated discs. I mentioned earlier poking the bear. If you can perform an activity like I mentioned that doesn't necessarily set you to the point where you're excruciating, remember, if you cause pain that requires surgical intervention that does not respond to the non-operative interventions, you're likely going to end up under the knife. Nobody wants that. Now, if it's something you love and don't really care if you might have to have surgery for a herniated disc, then I would say go ahead and play on, and you may have to deal with the circumstances of that. We have a lot of golfers. We operate on golfers. Again, we'll get you through the recovery period. We'll get you back out there on the greens.
Sure. And we have one more question. Just, do you take Medicaid or Medicare?
We do. Yep.
They do. Great. Thank you so much for your questions, and we really appreciate you coming this evening.
Great. Thank you. And again, be healthy and be safe. Wash your hands. Thank you.